Anecdotally, in my own clinic, I've had patients who have gone back into a complete response with T-DM1 after T-DXd.
I want to shift and talk about subsequent therapies after we use T-DXd, pertuzumab in the first line, let's say. And I think a common concern that we hear is, well, what do we do next after we've used T-DXdP? And I think this gets back to what we've been discussing, and that is, it does make sense both biologically and in terms of patient presentation to give your best therapies up front and optimize up front so that you're proactive rather than chasing the disease. But Dr. Macklin, what are your thoughts on how do you counsel colleagues who are concerned about how we sequence therapies after T-DXdP?
Yeah, I mean, I think, I can understand some sort of trepidation about thinking, because we know T-DXd is so effective, it's such a blockbuster treatment, that when, somebody progresses on T-DXd, the sort of gut reaction is, oh my goodness, they're not going to respond to anything now. But I haven't actually found that to be true in clinic. And of course, that sort of understanding comes from our experience with T-DXd in later line, which is how we started using the drug when patients had already had exposure to taxane, they've already had exposure to T-DM1, and probably had exposure to dacatinib. But the further up we move it into the first line, now we have all of those other treatment options still at our disposal. And because the chemotherapy is a different class, we're giving we're exposing the cancer to a different mechanism of action. So anecdotally, in my own clinic, I've had patients who have gone back into a complete response with T-DM1 after T-DXd, and I'm not that surprised because it's a completely different mechanism of action. So at that point, it's really understanding what is the current performance status of the patient, what are their current comorbidities, and what toxicities have they experienced thus far, and do they have brain mets or do they not, right? Dacatinib versus not. And, then making the best decision that makes the most sense for them.
Great. Dr. Javeri, are you following a similar paradigm in terms of how you sequence therapies? What are you doing after T-DXdP?
Yeah, I mean, technically, it's a little bit of a data-free zone in terms of knowing an optimal strategy or an optimal agent that we should definitely be using. I think it's not a one-size-fits-all approach even here, which is true for breast cancer overall, I think. But I agree with Dr. Macklin when he said, if I have a patient who's had progression on T-DXd, but I'm really worried about brain metastases and CNS progression, I'm reaching out more for, say, a HER2 climb regimen, which is what I did after DB03 as well. If I had used second-line T-DXd and I still was struggling with that, or even if it was not CNS progression, I was using HER2 climb. But here, if I use it up front, I feel like I also have taxanes to rely on, and I think they are a distinct mechanism of action. It's a completely different way, a distinct payload from T-DXd, and I'm able to use that as an approach as well. Certainly, T-DM1 is something we can use as well, but I think I am more leaning towards a taxane or a HER2 climb-based regimen first, and then thinking about T-DM1 after, if I'm thinking about utilizing T-DXd and pertuzumab up front.